Welcome to your deep dive today. We were looking through the pathophysiology notes you sent over, and I have to ask you to imagine something for a second.
Okay, I'm with you.
Usually when we think of these massive paradigm-shifting medical breakthroughs, we picture a high-tech laboratory, right?
Oh, absolutely. Glowing test tubes, microscopes, researchers in pristine white coats, logging data.
Exactly, the whole cinematic setup.
But what if the key to understanding a major, devastating digestive disease wasn't found in a lab at all? What if it was discovered in the middle of the brutal deprivation of a wartime famine?
Yeah, it remains one of the most astonishing and frankly tragic natural experiments in the history of modern medicine.
Right.
I mean, we had this moment where real-world starvation accomplished what decades of careful clinical observation completely failed to do.
Which is wild to think about. And to make the whole thing even crazier, modern medicine now takes that very same disease process, like a severe, potentially life-threatening malfunction of the human gut, and we intentionally cause it in certain patients on purpose as a treatment. We literally engineer the disease.
Yeah, it's unbelievable.
Yeah.
So today, our mission is to explore the fascinating and I think deeply misunderstood world of malabsorption.
A huge topic.
Huge. And we're going to use the really detailed clinical breakdown you provided to understand the mechanics of what happens when our gut betrays us,
Right.
when it just fails to take in nutrients.
Right. And to do that, we need to pull apart the origins of how doctors even define this condition in the first place. We have to look at the literal mechanical breakdown of the human digestive assembly line and explore some incredibly fierce debates happening in gastroenterology right now.
Because the downstream effects of this are massive, right?
Yeah.
Like the notes show this touches everything from global childhood nutrition to the hidden side effects of medications you might literally have sitting in your medicine cabinet right now.
Exactly. It's incredibly relevant to, well, pretty much everyone.
Okay, so before we even get into how nutrient uptake breaks down at a cellular level,
Yep.
we have to define what the breakdown actually is. Because reading through the clinical guidelines in your notes, there's this massive crucial distinction between maldigestion and malabsorption.
Right. Right.
And they sound like the exact same thing to me, but mechanically, they are worlds apart, aren't they?
They are completely different. To be incredibly precise with the medical terminology here, malabsorption is strictly the failure of the small intestine to transport digested nutrients. So your fats, proteins, carbs, vitamins, minerals, water across the intestinal mucosa and into your bloodstream or lymphatic system.
So it's the border crossing.
Exactly. It is uniquely and specifically about that final border crossing.
Let me see if I can visualize this just to make sure I have it right.
Go for it.
If we treat the entire digestive tract like a giant industrial assembly line, maldigestion is the factory itself breaking down. Like the machines fail to smash the raw materials into usable parts. But malabsorption is the delivery trucks failing to actually pick those finished, perfectly processed parts up and transport them into the actual city like the rest of the body.
That is a perfect analogy. Think about what happens upstream in that factory.
Okay.
Imagine your pancreas fails to secrete an enzyme like lipase. If that pancreatic fluid never reaches the gut, the fat you eat, say, from a piece of cheese, never gets emulsified.
So it just stays as cheese, basically.
Exactly. It doesn't get chopped up into free fatty acids. It just sits there as a raw, unusable material. That is maldigestion.
Got it.
Malabsorption, under the strictest definition, is a downstream failure. The cheese was digested perfectly, the factory enzymes did their job.
But the loading dock is broken.
Exactly. The physical intestinal wall itself, the loading dock for those delivery trucks, is broken, so the nutrients just wash right past it.
Wait, okay, but if the food is completely perfectly digested into these tiny molecular parts, why doesn't it just, I don't know, passively seep into the bloodstream?
It's a good question.
And more importantly, if they are completely different mechanical failures, why do doctors seem to blur the two terms together so often?
Well, the clinical reality is incredibly messy. First off, nutrients rarely just seep in. They require highly specific active transport channels on the cellular wall.
Oh, active transport.
Right. If those channels are damaged, the nutrient is basically trapped in the gut. But as to why doctors historically blurred the terms, it's because these two failures frequently happen simultaneously.
Oh, I see.
And they produce the exact same physical symptoms for the patient.
Right, the notes mention that. We're talking profound weight loss, chronic diarrhea, and severe nutrient deficiency.
Exactly. For a very long time, Doctors defined this disease entirely by what they could see.
Right.
If a patient had wasting and steatorrhea, which is the medical term for pale, fatty, foul-smelling, floating stool, they were just slapped with a diagnosis of a malabsorptive state.
But the pathophysiology breakdown you provided
Mhm.
highlights that this definition is completely shifted, right? Like, we don't just look at the gross physical symptoms anymore. Doctors are hunting for the specific mechanical broken gear.
Yeah, and this reframing fundamentally changes how we treat patients. I mean, a person can have severe, life-threatening malabsorption of just one single microscopic nutrient like vitamin B12 or iron.
Wow, just one.
Just one. While their gut digests and absorbs absolutely everything else normally, they might be gaining weight. They might have totally normal digestion.
So if a clinician is only looking for fatty, stool, and weight loss as the red flags, they're going to completely miss it.
They will completely miss that targeted, isolated cellular failure until it causes irreversible damage.
That shift from just looking at the broad symptoms to
Mhm.
hunting down the broken mechanics is so fascinating. And I know, to understand how the medical field got there, we have to talk about celiac disease.
We do.
Because reading this, it seems like the history of celiac basically shaped our entire modern understanding of malabsorption.
It absolutely did. And the timeline of discovery is full of these bizarre medical detours. It starts back in 1888 with an English physician named Samuel Gee.
Okay.
He delivered this now famous lecture called On the Celiac Affection. He vividly described children suffering from chronic diarrhea, severely distended bellies, and just a tragic failure to thrive and grow.
And he recognized that diet was the key to fixing it, right? But he was essentially flying blind.
It's totally blind.
Because looking at the history in the notes, he suggested these very sick children might be cured by a diet consisting heavily of mussels.
Yep, shellfish.
And then later, in the 1920s, an American doctor named Sidney Haas popularized a diet that was just incredibly heavy on bananas. Wait, hold on. Mussels and bananas? Are you telling me doctors were just throwing darts at a wall?
They were absolutely grasping at straws based on anecdotal success.
Got crazy.
A child would eat only bananas, their chronic diarrhea would stop, and the doctor would declare bananas the miracle cure.
Oh.
What they completely failed to realize was that these bizarre, highly restrictive diets accidentally worked because, by sheer coincidence, they happened to exclude wheat.
Oh. So the bananas weren't curing the children.
Right. The bananas weren't doing anything special. The absence of bread was. But the actual why remained a total mystery for another half-century.
Which brings us back to that wild hook from the beginning of the deep dive. The Dutch famine of 1944 to 1945. The Hunger Winter.
Yeah. The conditions in the Western Netherlands were apocalyptic. Nazi blockades cut off all food transport. The population was literally reduced to eating tulip bulbs just to survive.
God, that's horrific.
Bread and flour became completely unavailable. Over 20,000 people died of starvation.
But a Dutch pediatrician named Willem Carol Dick noticed a staggering paradox during this period of mass death.
He did. His celiac patients, the children who are already wasting away from this mysterious bowel disease, they actually improved dramatically when the bread supply vanished.
That is just... It's hard to wrap your head around.
Oh, yeah.
In the middle of one of the worst famines of the 20th century, these specific sick kids start thriving.
Exactly. And when the war finally ended and Allied food drops brought wheat flour back into the population's diet in mass quantities, Dick's patients immediately relapsed.
Wow.
Their severe symptoms returned almost overnight.
So it was undeniable at that point.
Right. This horrifying natural experiment was formalized in his 1950 doctoral thesis. He proved that wheat, and specifically the gluten fraction of the wheat protein, was the causal trigger destroying these children's guts.
So suddenly, malabsorption wasn't just a vague, mysterious syndrome treated with bananas. It was a concrete disease with an identifiable, removable cause.
Exactly.
But knowing wheat is the enemy doesn't show you what the wheat is actually doing inside the body. Like, it just tells you to stop eating it.
Yeah.
How do the medical tools catch up to the theory so we could actually see the broken delivery trucks?
Well, the diagnostic toolkit required a massive leap forward, and in 1957, William Crosby and Walton Kugler developed something called the Crosby capsule.
I read the description of this thing in the notes, and it sounds medieval. I'm not
Yeah.
gonna lie.
It was a wildly inventive piece of engineering, but yeah, pretty intense. It was a small metal capsule attached to a long, flexible tube.
Okay.
A patient would literally swallow the capsule down into their small intestine. Once it was in position, the doctor would apply suction through the tube, which pulled a tiny piece of the intestinal wall into a hole in the capsule.
Oh, I don't like where this is going.
And then a spring-loaded circular knife inside the capsule would trigger, snipping off a tiny tissue sample, and they would pull the whole thing back out.
Yikes.
It sounds brutal, but for the first time in history, doctors could safely pull living tissue out of the jejunal mucosa and put it under a microscope without cutting the patient open surgically.
Unbelievable. And alongside that physical tissue sampling, the notes mention the D-xylose absorption test,
Yeah.
which sounds like the ultimate test of the factory versus the delivery truck analogy we used earlier.
It really is. D-xylose is a simple 5-carbon sugar, and what makes it medically brilliant is that it is absorbed totally passively. It does not require any pancreatic enzymes to be broken down first. It just slips right through a healthy intestinal wall.
Oh, okay.
So if you give a patient a dose of D-xylose and it doesn't show up in their blood or urine, you know unequivocally that the problem is the delivery truck.
The mucosal wall of the gut is physically damaged or blocked.
Precisely. But if they absorb the D-xylose perfectly, yet they are still malabsorbing their regular food, you know the wall is fine. The problem is upstream in the factory. The digestive machinery is broken.
That is such an elegant, simple piece of medical detective work.
Okay, so having established that we can pinpoint exactly where the gut is failing, I want to walk through the journey of a bite of food to see where the breakdown actually happens. Because the Pathophysiology document outlines 3 very distinct biological phases that have to work in perfect sequence.
Yeah, let's trace it. Think about the journey starting the moment food leaves your stomach.
Yeah.
This first phase is the luminal phase. This is the upstream digestion in the hollow space of the intestine. Food has to be chemically dissolved.
Right.
Pancreatic enzymes have to cleave proteins and starches. Pancreatic lipase, along with bile salts pumped in from your liver, has to emulsify fat so it can mix with water.
And a classic example in your notes of this failing is cystic fibrosis.
Yes, in cystic fibrosis, a genetic defect in the CFTR chloride channels causes the body to produce incredibly thick, sticky mucus.
And that mucus physically plugs up the ducts of the pancreas.
Right, exactly. Because of that blockade, roughly 85 to 90% of all CF patients develop what we call exocrine pancreatic insufficiency. So the lipase literally cannot get out of the pancreas to reach the duodenum.
Right, and the fat you ate passes right through your entire digestive tract, completely undigested.
So that's the factory breaking down.
There you go.
But let's say the pancreas works perfectly. The food is dissolved into these tiny molecular components. Now they actually have to cross the border into the cells lining the small intestine, the enterocytes.
Right.
This is the mucosal phase.
And surface area is the only thing that matters here. The small intestine isn't a smooth tube. It is densely packed with tiny finger-like projections called villi, and those villi are covered in even smaller microvilli.
Okay.
They give the gut an enormous absorptive surface area. Older physiology textbooks love to estimate that if you unfolded all the villi in a single human small intestine, it would cover the surface of a tennis court.
A whole tennis court crammed inside your abdomen. That is absurd.
It is. Now think back to celiac disease. When a patient with celiac eats a component of gluten called gliadin, their immune system mounts a vicious attack.
But it doesn't just attack the gluten, does it?
No, it attacks the intestinal wall itself. It burns down the villi. It flattens them completely into a smooth surface. This is called villus atrophy.
So you lose your tennis court.
You lose your tennis court, you lose your surface area, and you lose your ability to absorb nutrients.
But the surface area isn't the only thing that can break during this border crossing, right? The notes focus heavily on the specific enzymes that sit right on the surface of those villi.
Right, the brush border enzymes. They are the final gatekeepers. And the most common defect worldwide is lactase deficiency.
Lactose intolerance.
Exactly. Most humans naturally produce less of the enzyme lactase after they are weaned off breast milk. Without lactase sitting on the brush border, your body cannot split lactose into absorbable simple sugars.
So because it can't cross the border, the lactose just sits in the lumen, travels down to the colon, and ferments.
Yep, causing intense bloating and osmotic diarrhea.
Okay, so the food is digested, it navigates the tennis court, it crosses the border, and it's finally inside the intestinal cell. But it still has to be shipped out to the rest of the body. Long-chain fats get packaged up and sent into the lymphatic system, while other nutrients go straight into the blood.
Right.
This is the post-mucosal transport phase.
And a fascinating, if rare, example of this failing is intestinal lymphangiectasia.
Okay, what is that?
The lymphatic vessels inside the intestine become severely dilated and physically obstructed. Because the forward path is blocked, the pressure builds up, and the nutrient-rich, milky lymph fluid actually leaks backward.
Backward.
It ruptures right out of the vessel and leaks back into the hollow gut lumen. You experience a severe, dramatic loss of fat and protein that you had already successfully digested and absorbed.
Leaking backward into the gut. So you're literally losing the exact cargo you just spent all that energy getting onto the delivery truck.
You are bleeding nutrients back into the waste stream. It's incredibly frustrating physiologically.
Okay, here's where it gets really interesting, though. The clinical notes mention a fourth wildcard factor that can disrupt this whole process. SIBO. Small intestinal bacterial overgrowth.
Yes.
When I was reading the mechanism for this, SIBO sounds exactly like pirates hijacking the cargo ships before they even reach the port.
It's a great way to think about it. Your small intestine is designed to have a relatively sparse, controlled bacterial population compared to the, dense jungle of the colon.
Right.
But in SIBO, bacteria proliferates upward into the small intestine where they don't belong. And they are hungry. They directly consume massive quantities of things like vitamin B12 before your body even has a chance to absorb it.
But the notes say they don't just eat the food, they actively sabotage the digestion process itself. How do they do that?
They chemically dismantle your digestive tools. We mentioned earlier that your liver produces bile salts to emulsify fat.
Yeah.
Well, the bacteria in SIBO deconjugate those bile salts. They break them apart prematurely. Without intact bile salts, you can't digest fat. So SIBO basically hijacks the luminal digestion phase and the mucosal absorption phase simultaneously. It is a dual assault on the system.
Because there are so many overlapping stages, and because the clinical symptoms can look utterly identical regardless of where the break happens, the medical field is still wrestling with some pretty fierce debates.
Oh, definitely.
Looking at these notes, one thing that really jumps out is the widespread confusion around celiac disease as a food allergy. People use those terms interchangeably, but it's fundamentally incorrect.
It is not a classic allergy, and distinguishing the two was a massive battle in the medical literature for decades. The discovery of specific autoantibodies like tissue transglutaminase or TTG, along with specific genetic markers, completely settled the debate.
Okay.
Celiac is a systemic, autoimmune, T-cell-mediated mechanism.
Whoa, hold on. A T-cell mediated mechanism. Contrast that for me. What exactly is a classic allergy doing differently?
Think about a severe peanut allergy. That is an IgE-mediated hypersensitivity.
IgE. Got it.
It relies on a totally different wing of the immune system. You eat a peanut, the IgE antibodies instantly recognize it, they trigger massive histamine release, and you immediately have a severe acute reaction hives, swelling, potentially anaphylaxis.
It's fast and explosive.
Exactly. Celiac disease, because it's a T-cell autoimmune response, can smolder silently for years. You might have zero obvious explosive digestive symptoms while your immune system slowly, methodically flattens that tennis court inside your gut.
Which leads perfectly into the second major debate, which feels incredibly relevant to mainstream culture right now. Non-celiac gluten sensitivity.
Yes, NCGS.
Let's say someone feels significantly demonstrably better when they stop eating gluten, but their blood tests for celiac antibodies are totally negative, their biopsies are clean, and their allergy tests are negative. Is it just a psychological effect?
This is one of the most fiercely contested areas in modern gastroenterology. What's fascinating here is we genuinely do not have a definitive answer. Yeah. Some researchers believe it is a unique, undiscovered immunological reaction that we simply don't have the tools to measure yet. Others argue it isn't the gluten protein at all, but rather a reaction to fermentable carbohydrates in the wheat, what we call FODMs.
Oh, I've heard of FODMN.
Right, which cause bacterial bloating. And yes, a large contingent argues it is heavily influenced by the placebo or nocebo phenomenon. It sits very awkwardly next to these beautifully defined mechanical diseases we just discussed because we simply can't point to a specific broken gear.
The clinical notes also point out that SIBO diagnoses are a massive source of friction in the medical community right now, too.
Oh, absolutely. The primary way doctors diagnose SIBO is through a breath test. You drink a specific sugar solution, and the doctor measures the hydrogen or methane gases you breathe out as the bacteria ferment that sugar.
Sounds straightforward enough.
You'd think so, but those tests are heavily criticized for having notoriously inconsistent sensitivity and specificity. Many top experts argue SIBO is currently being vastly overdiagnosed.
Because it's trendy.
Exactly. It's becoming a trendy catch-all explanation for anyone with unexplained bloating or irritable bowel symptoms. even when the actual underlying mechanism might be completely different.
Let's run through a few common misconceptions that the pathophysiology notes specifically tried to debunk, because I think you listening might have a very rigid idea of what this looks like. The first assumption is that malabsorption always, universally causes diarrhea.
This is a dangerous assumption for a doctor to make. As we mentioned, with isolated malabsorption of B12 or iron, the only symptoms might present entirely outside the gut.
Right.
A patient might come in with profound fatigue, severe anemia, or mysterious neurological tingling in their hands and feet. Their stool might look textbook normal because they are absorbing all their bulk calories and fats perfectly fine.
Another assumption is that if a doctor scopes you and the villi look normal on a biopsy, you can definitively rule out a malabsorptive disease.
But remember, lactase deficiency. A patient with a brush border enzyme defect has perfectly healthy, normal-looking villi under a microscope.
The structure is flawless.
Flawless, but they are still chemically failing to absorb specific sugars. Or, as we discussed with cystic fibrosis, the intestinal wall is pristine, but the problem is miles upstream in the pancreas.
The one that really caught my eye in the notes is the assumption that fat malabsorption is just about losing dietary fat and calories.
Right.
It's like, oh, well, I just won't absorb the butter.
Yeah.
But they are inextricably linked to vital micronutrients.
Fat malabsorption is almost never just about fat. Vitamins A, D, E, and K are fat-soluble vitamins.
AD.
Exactly. They fundamentally require the exact same digestive machinery, the bile salts, the lipase, the micelle formation, to be absorbed as a piece of dietary fat.
So if you lose your ability to absorb fat,
You are simultaneously dragging down all four of those vitamins, creating a massive systemic multivitamin deficiency. This is exactly why cystic fibrosis patients don't just take pancreatic enzyme pills. They require heavy, specific ADE vitamin supplementation.
which shatters the final misconception that malabsorption is basically just a mild food intolerance, like something annoying that gives you an upset stomach but isn't actually dangerous.
Tell that to a patient who has lost their ability to absorb vitamin K. Vitamin K is absolutely essential for your liver to synthesize clotting factors.
Oh, wow.
If you can't absorb it because of chronic fat malabsorption, your blood literally cannot clot properly. You can suffer spontaneous, life-threatening hemorrhaging.
That is terrifying.
Severe unchecked celiac disease can strip the body of calcium and vitamin D so thoroughly that it causes profound early-onset osteoporosis and, in children, irreversible growth failure. It is an incredibly dangerous systemic failure.
Transitioning from the cellular level to the global scale, the clinical notes make it clear that this isn't just a historical curiosity or a rare genetic fluke. It dictates health outcomes on a massive scale for all of us.
It does. Chronic diarrheal and malabsorptive disease remains a leading driver of childhood malnutrition and stunted growth globally. In low-resource settings, this isn't just about celiac disease. It is often driven by conditions like tropical sprue, persistent parasitic infections like giardiasis, and a condition called environmental enteric dysfunction, which chronically blunts the intestinal villi due to repeated pathogen exposure. It is a staggering global health burden.
But in wealthier settings, the notes point out something that completely blew my mind. We talked about this at the very beginning of the deep dive. We are actually causing this disease on purpose. We engineer a malabsorptive state as a therapeutic tool.
Roux-en-Y gastric bypass surgery, one of the most common bariatric procedures in the world, works precisely by deliberately bypassing a large segment of the small intestine.
So surgeons intentionally induce a controlled degree of malabsorption.
Yes. They physically shorten the delivery route to purposefully reduce nutrient and calorie uptake to treat severe obesity. We turned a pathological mechanism into a therapy.
But you can't just break the delivery truck on purpose without consequences, right?
You absolutely cannot. Those patients require intense, lifelong vitamin and mineral monitoring as a direct expected consequence of the surgery. We bypass the absorption surface, so we have to manually ensure the critical micronutrient packages still get delivered via lifelong supplementation.
There's also a hidden danger discussed in your notes involving a medication that millions of people take every single day, metformin.
Yes. The frontline treatment for type 2 diabetes.
Long-term use of metformin is a recognized, proven cause of vitamin B12 malabsorption. But what's terrifying is how long it takes to actually notice the damage. How do you miss a vitamin deficiency for years?
Because the human liver is an incredible storage vault. Your liver stores a massive reserve of vitamin B12.
Okay.
Let's say you start taking metformin, or you develop a disease process, and it completely shuts down your gut's ability to absorb B12 today. Your blood levels won't drop tomorrow. The liver just quietly starts dipping into its reserves to keep your brain and nerves functioning.
It's completely masking the problem.
Completely masking it. It can take 3 to 5 years for that hepatic reserve to finally run dry.
5 years.
The malabsorption can smolder silently for half a decade before it suddenly crosses a threshold and shows up clinically as irreversible neurological damage. The true cause is remarkably easy to miss because the inciting events starting the medication or damaging the gut wall happened years ago.
We have covered some incredible ground today. From understanding that malabsorption is specifically a failure of the gut wall, the delivery truck failing to load the cargo, not the factory failing to process it.
Right.
We walked through the luminal, mucosal, and transport phases to see exactly where the bottlenecks occur. We saw how brilliant, albeit intense, diagnostic tools like the Crosby capsule and the D-xylose test let doctors figure out exactly where the break is. We learned how the horror of the Dutch famine accidentally unlocked the mystery of celiac disease. And we learned why fat malabsorption is so systemically dangerous, because it drags vital fat-soluble vitamins down with it.
When you look at all of this, from surgical interventions to the hidden side effects of common drugs, it raises a profound implication.
What's that?
Well, if modern medicine can intentionally use gastric bypass surgery to permanently turn down our nutrient absorption for weight loss, and if a common drug like metformin can accidentally turn off the absorption of a specific molecule like B12, it raises an incredible question.
Yeah.
Could the future of medicine involve precisely dialing up or down our absorption of specific nutrients to treat disease? What if we start treating the human gut not just as a passive wall that occasionally breaks down, but as an interactive control panel we can pharmacologically program?
Wow. Something to chew on next time you eat. Thank you for joining us on this deep dive. Stay curious, and we'll see you next time.